common compliance pitfalls. So anyone who's heard me speak before will know that I always try to introduce a little bit of humour and humanness into all my presentations. And this one will be no exception. So for those of you I've never met or don't know who I am, I'll tell you a little bit about myself. I am first and foremost a dentist, a slightly weird dentist, I have to say, because my passion is compliance and supporting practices with everything to do with regulatory compliance. So that could be CQC, it could be any of the other regulators, it could also be GDC issues. And I've kind of made a career out of it, actually. So my journey to get here, so everybody goes on a journey these days, was that I started out, qualified from Manchester a very long time ago, and then over the years developed a passion for what used to be called quality assurance and then was called clinical governance and now is called compliance. It is all the same stuff. So my other passion is training. So this today is a dream for me, and I will do my best not to turn it into a nightmare for you. So this is what we're going to talk about today. And I hope that I can share some useful information with you today. So before I start, though, a very big thank you to the Dental Care Provider Board. They are funding a series of webinars for you guys in the Greater Manchester area. So this is the first of the webinars, and there will be 6 more over the next 6 months. Now, today's is all about the CQC and compliance. The next webinar and all the webinars after that, we will take one or more of the Mythbusters from the CQC's website, which I'm sure most of you will be familiar with, and explore that. And so that is the idea for our series of webinars. Now, at the end of this webinar, the team at the Dental Care Provider Board will send out to you a feedback form. Please do feel free to put on that any other subjects that you'd like, that you would find helpful, and I'll attempt to weave those into what we're going to do over the next few months. The team will also send CPD certificates as well. Plus, I will provide to the Dental Care Provider Board a copy of this presentation and also a PDF, and that will be sent out to everybody as well. It's also being recorded so that we can reach as wide an audience as possible. And, you know, I am so grateful to the Dental Care Provider Board. To my knowledge, nobody else is doing this, so you guys are very lucky. Not surprised it's Manchester, having trained there as well. So I'm really pleased to be doing this for you all. So that's what the plan is. And today we're going to talk about the CQC, and it is changing. And it might feel like they change all the time, and kind of they do evolve how they do things. But really the last major change to how they inspect and regulate was in 2015. They're now in the process of another major change, but they are having learnt from previous experiences, they are taking this one a little bit more slowly. And they have what they've called a single assessment framework. So it's only new-ish because it's been around for a couple of years now. And in fact, they started inspecting dental practices against the new framework in May last year. So it still is relatively new. Now, if that makes you feel, as I'm sure it will make some of you feel as if this is a ghoul coming out of the mists at you, then that's what I'm here to do today, to try and dispel any feelings of dread. Although I do suspect many of you will feel like the gentleman on the right there tearing his hair out. So let's get going. So the aims today, provide an update on how the single assessment framework is affecting us in our practices. And just for the record, I am no longer a wet-gloved dentist, but my husband is in our practice. And so I feel his pain on a daily basis. So his pain will be similar to your pain. And so that's why I hope I can be helpful. We're then going to look at the common compliance pitfalls and how best to avoid them. By the end of it, the learning outcomes, and this will be what goes on your CPD certificates, is that we're going to look at the CQC single assessment framework. We're going to look at what's changing and what isn't, because not everything is changing. We're also going to just consider what's likely to change over time. And then perhaps the most important part of this is how to avoid getting this wrong in the meantime. So, single assessment framework. Well, this is what the CQC says about it. So our framework assesses providers, local authorities, and integrated care systems with a consistent set of key themes. There you are. We don't need to go any further. That's it, all beautifully explained. But if you would like to think about it in plain English, all it really means is that the CQC is going to involve everyone involved in health and social care. So that's us, care homes, that's GP practices, that's hospitals, everyone they regulate. They're going to inspect them and regulate them and assess them all in the same way. So it is not jargon to be frightened of. It is as simple as that. So we're going to look at what isn't changing, what is changing, what's been delayed, and what will change over time. The problem with that, though, is that nobody really likes change. And this kind of is an ongoing thing that has been around forever. And so this book called The I Ching was written around about 2000 BC. And the book asserts that the only thing that never changes is that everything changes. And how true is that? So we shouldn't fear change, but we do, don't we? So let's look at simplifying things. So let's first of all look at what is not changing. Now, this is a really important thing that is not changing, and it is really good. So the CQC has what it calls its 5 key questions. And essentially, they want to know that providers, so that's us in dental practices and all other parts of health and social care, are providing care that is safe, that the care we provide is effective, that we are caring, that we are responsive to our patients' needs, and that our practices are well led. Another piece, all of which is good stuff, you can't argue with any of that. And the other really good piece of news here is that if you are doing all of these things really well now, so you are good, then going forward in the new single assessment framework, good will still be good. And that is good news. So they're not moving the goalposts on what counts as being good. That also does mean, though, that it is the same for practices that are only managing to be safe, effective, caring, responsive, and well-led averagely well, or they need to improve. So that will not change. And poor practices will still be poor, and sadly, dire practices, of which there are some, will still be dire. This is one of my favourite photos there, which you may not know what it is underneath the question mark. That is a Henry Hoover plumbed in to be a suction motor. That it's quite a famous photograph. It did happen to be one of our clients that we were supporting, and it has been used actually by the CQC. So unsurprisingly, the practice that thought it was okay to have a Henry Hoover as a suction motor did actually was closed down, and we had to drag them kicking and screaming into, well, probably the 20th century, not even the 21st century. But I think it was a single-handed practice, and they'd kind of just lost their way. So that good will still be good, but the other things also will remain the same. The regulations are not changing, so all that the CQC is coming to look at is still governed by the Health and Social Care Act, so that has not changed at all. 10% of dental practices, that's what the CQC has been doing for years now, and that's not going to change, so it'll only be 10% of dental practices that are inspected annually. These inspections will either be risk-based, so that is where there's been some kind of problem, so a previous problem at an inspection, or a whistleblowing, or some kind of concern the CQC has from somewhere, or they will be random. And so the CQC doesn't publish ratings for dental practices, as in whether you're good, outstanding, or the other ratings they publish, because they only inspect 10% of dental practices annually, and it wouldn't be fair to rate the 10% and not the 90%. So as far as I understand, and I do speak regularly to the guys at the CQC, there are no plans to change that. So they're going to focus on practices which they describe as not having inspected for a long time. What they don't do, though, is define what long time means. They're also going to focus on practices that have never been inspected. And the last time I spoke to them, they told me that there were around 2,000 dental practices that have never been inspected. I was quite surprised at that, and you might be too. They will also focus on practices that they have concerns about. We've covered that already. So what kinds of the key areas are they going to be looking at? Well, infection control is always a focus. Robust recruitment processes has become more of a focus. Checking that practices have sufficient competent staff, and these two, and actually the next one, training and supervision, are kind of linked. Because, as we all know, we're living through very difficult recruitment times indeed, and it can be tempting to take on people without all due process and all the required checks. We'll cover that in a lot more detail later. Certainly where our practice is, we really, really struggle with recruitment, and I wouldn't be surprised if many or most of you do too. So equipment and premises will always be a focus, making sure care is evidence-based. Good governance, that is always a focus too. So that is how well managed and how well run your practice is, and it otherwise known to the CQC as whether or not it is well led. And well led and safe are the two of the 5 key questions that usually trip most practices up. So they also look at safeguarding. They're concerned about consent and patient records. Medicines management is quite a big thing as well. Complaints, and demonstrating that your care is caring and responsive. So in other words, very, very similar to what they look at now. And all of those things they're not unique to the CQC. They are how things should be done. I should say, actually, and I forgot to mention it at the beginning, if you have any questions on the way through, please either put them into the chat and I'll answer them at the end, or please save your questions up and raise your hand at the end and I will answer them if you'd like to come on and speak, so that we have a conversation. So, and then also what I always say about questions is that there is no such thing as a daft question. So if you're sitting there, I wonder what if somebody else might be as well. So please ask as many questions as you want. We've left lots of time for questions, just to see how we can best help you. So really, just to reassure you that their focus is very, very similar to their current areas of focus. And some practices being inspected will notice a change and some won't. If you had your last inspection before April 2015, or perhaps going back to 2011, 12, 13, 14, you will definitely notice a huge difference. If, however, your inspection was in the last few years, bearing in mind that practices are selected randomly in addition to practices that are problematic to them, then you will notice less difference. So that's good for the practices inspected recently, not so good if you were inspected before April 2015, because it is like a completely different inspection. So those are the things that aren't changing. Let's now look at what is changing. so the key lines of inquiry, otherwise abbreviated to the CLOEs, have been replaced by 34 quality statements and evidence categories. I'll talk much more about that just in a second. So that is changing. The CLOEs have been replaced, and so also is how they report on their findings. And again, more of that in a moment. So just to recap on what the CLOEs were. So key lines of inquiry came in 2015. And the aim of these was to guide the inspection and create consistency. And they were moderately successful, but really probably no more than moderately successful. One of the big issues that the CQC grapples with is inconsistency between inspectors. We had our last CQC inspection in our practice was 9 hours in the practice, maybe 2 or 3 years ago. 9 hours in the practice, went through absolutely everything, and actually my husband asked the inspector at the end if she used to work for MI5. So it was huge. Other practices don't have that same experience. I don't think it was just because of CQC knowing what I do. I don't think it was that at all. I think it was just that some inspectors have a method that really is extremely thorough and others less so. So the CLOEs were designed to try and create consistency. They were never a rigorous checklist, although I was involved in the early steering groups and I did ask for a checklist, but we were told that that was never going to happen, and fair enough, it never did. So these CLOEs have been replaced by these 34 quality statements and evidence that you as a dental practice comply with the quality statements. And the quality statements are similar to the CLOEs, and like the CLOEs, they are designed to guide the inspection. But it is a little bit more, well, you'll see, I'm going to show you a couple of the quality statements. It's perhaps a little more difficult, I think, to follow what it is they're actually looking for. But if you keep in your mind that really all the stuff that we have to comply with in practice is stuff we've always had to comply with. The difference now, obviously, is that CQC is coming to check that we do comply with things. And actually, Mr. Henry Hoover and his ilk would tend to suggest that this is definitely something that should be happening. So there are 34 key quality statements, and these are mapped to the 5 key questions, which you'll remember are safe, effective, caring, responsive, and well-led. And the inspectors will decide on what statements and evidence categories are relevant in dental practices, and then specifically in your dental practice. So if they go down one line of questioning and they have things that they may think are just not quite where they should be, they might go off on that tangent, or otherwise known as a bit of a rabbit hole, and then ask many more questions. So not all of the quality statements will be sampled on every inspection. And of course, no practice has any way of knowing, and actually the inspector doesn't know either till they get there probably, which statements will be sampled in which practices. So it does sound all a little bit more airy-fairy. Just keep in mind, though, that they're looking at all the same stuff. You know, because radiation protection's radiation protection, infection control's infection control, and they've always been the same. So the quality statements focus very much on continuous improvement. So that is saying this is where you are now, and how are you going to improve and move on? Now, continuous improvement can be demonstrated through essentially 3 different mechanisms. So one is through feedback. That's feedback you get from your patients and feedbacks you get from your team members. So by seeking feedback and acting on it, that demonstrates that you are continually improving. Audit and risk assessments are other two ways of demonstrating continuous improvement. So in audit, you undertake an audit, and then you need evidence that actions that have come out of the audit have been acted on, and the same with risk assessments. And if you don't act on the actions, then basically you are doing a pointless tick box exercise, which is a waste of everyone's time. I'll come back to that in a bit more detail in a minute. So this is good. Continuous improvement is good. What is new is that there is a focus, not a massive focus, but a focus, which was missing before, on environmental sustainability. And what I was hoping they would be looking for is something more than they're actually looking for, but maybe that's a good thing for now. So they want what I think would be fair to be called a proportionate evidence of awareness of the impact of what we do in practice on the environment. So that doesn't mean that you focus on that to the exclusion of safety, infection control, radiation protection, good governance, and all of those things. It's kind of something that you're doing because it's the right thing to do. So thinking about what can we do to look at how we can have, as a practice, how we can have less impact on the environment. And of course, in dentistry, we have a huge impact on the environment. So we have far too much, in my opinion, single-use plastic. So just perhaps be thinking about whether you can reduce some of that. We're not going to go into that in detail today. But there are things that you can do to reduce the impact, both from team members' behaviour and also during treatment. So all they're going to really expect is that you've just thought about it, which is a good thing. There is also a newish focus on equality, diversity and inclusion, patients and staff with protected characteristics, and staff wellbeing. Staff wellbeing has particularly come out of the pandemic. So, and they are put over the quality statements, and maybe you've had a look at them and maybe you'd like to after this, but they are statements that practices should live up to. And they're expressed as we statements. And what I mean by that is that it's saying we in our practice do this to live up to the quality standard. And what you then need is evidence that you live up to that quality standard. So we're going to look at infection control in a minute and just think about how that works for infection control. CQC says they show what is needed to deliver high quality care. I think that's a bit of an overstatement there, though, because I think it can be a little bit difficult to interpret what they're looking for. The aim with this is for the CQC to be more consistent, because as I said earlier, it is a concern to them that they aren't completely consistent. My view would be that it isn't really possible to be completely consistent when inspecting a practice. So the quality statements, as I said a little while ago, are mapped to the 5 key questions. So there are 8 quality statements contained within the safe key question, 6 within effective, 5 within caring, 7 within responsive, and 8 within well-led. And it just so happens that safe and well-led are the areas that most often trip practices up. So let's have a quick look now at a couple of quality statements. So this is one from SAFE. So this is the we statement. So we in our practice assess and manage the risk of infection. We detect and control the risk of it spreading and share any concerns with appropriate agencies promptly. Latter part of that doesn't really apply massively to us in dentistry. It's more to do with hospitals. So think about what evidence is needed for compliance. Now, one of the things that I think may be very helpful for you to do is when you get the presentation, perhaps use this as a training tool within your practices. So for an in-practice training session. So think about what evidence is needed for compliance with this quality statement. Well, it's things like complying with HTML 105. It is your infection control audit, your your policy, your procedures, all of those things. And that is the evidence that they are looking for. Well led, here's an example here. So again, these are direct quotes from the quality statements themselves. Effective governance and management systems, information about risks, performance, outcomes used effectively to improve care, inclusive and positive culture of continuous learning and improvement. And again, think about how you would evidence all of those things. And indeed, think about all of the evidence that you need to evidence that you do comply with the quality statements. Now, but as I've said a few times now, this is mostly the stuff you already do. This is not new stuff. You're just having to think about it in a slightly different way. So it's like the CQC has taken a compliance jigsaw, they've broken it up, tipped all the pieces on the floor and said, right, put that back together. It is all the same stuff, just repackaged. And so what we need to do is to put the jigsaw pieces into the new picture, but they are the same jigsaw pieces. Reporting has changed, as I mentioned a little while ago, and so how inspectors assess compliance and draw conclusions is changing. So for each applicable evidence category, they will either assess that evidence category as all the regulations have been met or all the regulations have not been met. And that is it sounds like it's a very binary assessment, which it is. What they then do, though, is they take those assessments to draw conclusions from the assessments. So they might say, well, not all the regulations were met. What do we think? And they discuss it as a team. What do we think about this practice? Is it safe, effective, caring, responsive, and well-led? Or do they need to make changes to demonstrate they are safe, effective, caring, responsive, and well-led? Or in the worst possible case scenario, do we actually need to sanction them until they do meet these requirements? And, you know, as I said, Mr. Henry Hoover, that's not a photo from the 50s, 60s, 70s, 80s, 90s. That's from a few years ago. So there are still horrors out there. So they will make these assessments, regulations met or regulations not met, and then they will draw their conclusions on what needs to happen as a result of that. I will touch extremely briefly on the CQC provider portal, which it is fair to say has not gone very well. By their own reckoning, it has been a bit of a disaster. And as a result, it is only partly functional. And you know, new portals are really, really difficult to get right. And so they made a very sensible decision in November 24 to remove some of the functions from the portal until they can fix the techie glitches, and they have reverted to email forms. Now, undoubtedly, at some stage, they will move forward again with the provider portal. But for now, if you can't report some things on the portal, if you can't get onto the portal, then there are email forms, which is good. So has anything else changed? Well, yes, actually, a few other things have changed. So there does appear to be more non-compliance now than before. When I say before, I'm probably talking pre-COVID. Because pre-COVID used to be about 90% of practices didn't have any action. Now it's about 85%. I think they have realised that visiting 10% of practices is probably not enough, and that has allowed some baddies to slip through the net. And they are now focusing on practices that haven't been visited for a long time, or indeed ever. So I think it's not surprising that the number of practices that need to take some kind of action is not as high as it used to be. So let's have a look at why is this? Well, is it because the CQC, this is one of John Milne, National Senior Dental Advisor to the CQC. This is one of his favourite expressions about CQC inspectors having sharp pencils. So are their pencils sharper? Probably. Are their inspectors more knowledgeable? Definitely. And of course, they are prioritising practices that haven't been inspected for a long time. I do think, though, that there is more to it than that. And I do think, from experience, that it is very easy to let things slip. So in my hugely long experience of going into practices to help them with clinical governance, compliance, quality assurance, my finding over the years has been that you can go in and do an audit for a practice and you can find that, let's say, A, B, and C are not compliant, everything else is. And then you go back after a period of time and A, B, C has been put right, but X, Y, and Z is now has now slipped off the radar. So that happens for sure. I know that from personal experience. I think also in this pretty difficult working environment, it is very easy to be too busy for compliance and to stop seeing the dangers and to take off our safety helmets and therefore get stuck in the mousetrap with the bit of cheese. So I think it is very easy to just think, oh, well, compliance will take care of itself. It doesn't, though. So it does involve ongoing work on a regular basis. So we're going to look now at what the frequent areas of non-compliance are. I think actually I will just check the chat to see if there are any questions in there that it would be good to answer now. Does change of owner, thank you for asking that, does change of owner trigger a CQC inspection, or would it be changed if registered manager or both? Possibly. And so nothing happens all the time. I think if it was a practice that perhaps had concerns in the past, they'd had concerns in the past about, then almost definitely it would trigger a CQC inspection. If it's one that's gone under the radar and has had and been inspected relatively recently, then maybe not. All new squat practices, of which there are hundreds actually happening all the time, they do all have a pre-opening inspection. So thank you for asking that. I shall move on now, and we're now going to look at these pitfalls, and I've taken these pitfalls and common areas of non-compliance from CQC findings 23 to 25. Also, just as importantly, our experience of sending our compliance advisors into practices to do mock CQC inspections. So these are the top recurring areas of non-compliance. They come up frequently in CQC inspections, and when we carry out mock CQC inspections for our members at Dentistry Compliance, we unsurprisingly find the same things. So let's go through these one at a time. So we're going to look at what the area of non-compliance is and what you can do to avoid that pitfall. So this is a big one. And it causes masses of problems. So this is out-of-date, unsigned policies and protocols. Policies don't reflect what happens in your practice, or they are not understood by the team. And this is often caused by what we, I think, politely refer to as policy overload, and less politely refer to as death by paperwork. So that is practices that just have far too much paperwork. And so what can you do about that? Because actually, if you do have far too much paperwork, then having far too many policies, protocols, and so on to stay on top of all the time actually causes non-compliance. So it doesn't help you, it causes non-compliance. So what can you do about that? Think very carefully about whether you need all the policies you've got. Declutter them, make sure that you only have the ones you actually need. For example, you don't need a CCTV policy if you don't have CCTV in your practice. That might sound simple. Our finding has been, though, that practices think they have to have a policy for everything, and eventually they have a policy for having a policy. And that is what causes this death by paperwork. So make sure you only have the policies you need and not the ones you don't need. Also, make sure they're up to date, in date with a review date, and make sure they are signed and understood by all. The understood bit is quite tricky. If as a team member presented with a big load of policies to read and sign and say you've understood, do you think that everybody stops to understand them and make sure they know what's in them, or do you think they just sign them? Well, call me cynical, but I think most people will just sign them. So suggestion around how you get around that is to have what we call actually, and which we have in our system, a policy training assessment. So then take a policy, or maybe two policies, go through it in a practice meeting. This counts as in practice training, by the way. And then at the end of that meeting, ask your team members just to answer a few small questions on the policy. And that way you will know as a practice manager or practice owner that they have actually understood them. But it's a good way of familiarizing your team with policies, but in bite-sized chunks. What else? So we see incomplete or absent or out-of-date risk assessments and audits, particularly things like fire. Now, fire's a really big one, particularly since Grenfell, and that will always be focused on. So just make sure that your fire risk assessment is up to date. We recommend that practices who that you have a fire risk assessment done by a qualified authority as a starting point, and then thereafter you can do your own fire risk assessments, provided nothing's changed. Health and safety, general practice risk assessment, COSH, infection control. These are the things that we frequently find are absent, out of date, or just not being done. Another thing we find is that they are present, but there is no evidence that findings have been acted on. Perhaps even worse, the audit doesn't reflect reality. So I did a training session some while ago for a lot of practice managers, and there was one practice manager, and it was really, really concerned. And she said that she had discovered that their infection control audit, for somehow that the practice team member doing the audit had got the impression that all they needed to do was to go through and tick the boxes, didn't have to actually look at whether it was accurate or not. I don't think you need me to tell you, complete waste of time and probably paper and money. So you must make sure that the audit reflects reality. What can you do to make sure that you are as certain as you can be that they are all being done appropriately? So make sure they're being carried out at the right intervals. Make sure you have some means of prompting yourselves when an audit or risk assessment is due. Decide who's going to do it. I strongly recommend that you share out these tasks among the practice team members. Compliance is a team effort and should not be left only to one person to do. So the infection control lead should do the infection control audit, the safeguarding lead should do the safeguarding audit, and so on. And then you will find this is a slightly boring but necessary recurring theme. Make sure that the actions that are coming out of the audit have actually been acted on. And never, ever, ever do risk assessments or audits as a pointless tick box exercise. It will do nothing for you. It'll do nothing to demonstrate that your practice is safe, effective, caring, responsive, and well led. It's a waste of time and probably a waste of paper and money. So that's really important. We do see that a lot. Moving on now, a poor understanding of the importance of significant events in continuous improvement. Now, I talked at the beginning about how and actually it was always there as a theme anyway, and a well-run practice should always be looking to continually improve. And significant incident reporting, investigating, and actions can be really important in continuous improvement. So let's say you take a significant event. Now, I think there is a lot of misunderstanding about what a significant event is. So I'm going to tell you what my definition of a significant incident is. It's something that is significant to the running of the practice. That might sound obvious, but I think a lot of practices have the idea that it's something catastrophic. So patient dies in the surgery, the X-ray arm falls on them. It is basically anything that just doesn't go according to plan. And that is that is significant to how you run your practice. So it could be something as simple as you've got somebody, a member of the team, either an associate or a member of the other member of the team, and they're always late for work. Well, that's a significant incident because that will impact on your ability to run the practice and also potentially on patient care. So that's a significant incident. So that should be recorded, discussed, learnings should come out of it, and then you should act to make sure that you stop it happening. So why bother? Well, one of my favorite quotes, which Albert Einstein didn't say, but everybody says he did, but I have researched it extensively and apparently he didn't say it. However, it is true. The definition of insanity is doing the same thing over and over again and expecting a different result. So if after you've had a significant incident or two significant incidents that are the same, you don't make any changes, then the same thing will go on happening. So it is a good thing to do because, as I say, it can be very impactful indeed on patient care. Servicing, next one, servicing, inspection, validation, maintenance is out of date or no evidence has ever been undertaken. You might find that almost impossible to believe, but it does happen. Mr. Henry Hoover was a great example of that. We've also had experience of going into practices where they haven't had any servicing, inspection, validation or maintenance for, I think the longest we saw was 7 years. So do make sure that that is happening, and make sure that you schedule or have prompts for all of that stuff to happen. And there are various different ways that you can do it. So how could you make sure that happens? Well, you could keep a paper diary, increasingly rare these days, I know. You could have an electronic board, you could have a whiteboard in the staff room, you could do it post-it notes, or post-it notes fall off though, so be careful about that. Or other. When I say other, I mean through a compliance system. So there are lots of different ways you can do it. Whichever your choice is, just make sure you do schedule the tasks. Moving on to the next one now, incomplete patient records. Now, bear in mind that on all CQC inspections, there will be a GDC registrant, and they will know what they're looking for. So perhaps the CQC non-dentist or non-GDC registrant won't, but the GDC registrant will. So they will look at patient records and they will be concerned if they're incomplete, and so they should be. And another issue is quite often over-reliance on templates, which I could spend another whole session talking about that, and we probably will on some of the webinars going forward. Poor evidence of valid consent, and actually poor evidence of understanding what valid consent is, and just not realizing that your consent may not be valid. I'll talk a bit more about that later on. And then infrequent or inadequate patient records audits. So you should be undertaking patient records audits. Now, this is a personal view, which you may or may not agree with. It is my personal view, though. I think that it's essential for all clinicians to audit their patient records, not have somebody else do it. Bear in mind, clinicians, if we have clinicians listening and watching, that the whole purpose of a patient record audit is to protect you. and to make sure that your patient records are going to stand up to scrutiny. So delegating that to somebody else is probably not the best idea. I am very aware that it is very common that clinicians don't audit their own records. I would really encourage clinicians to do this, though. And when you're auditing, make sure that the records reflect the CG Dent, used to be FGDP's guidance standards, because that is the standard by which records will be measured. When you are doing, and I'm speaking to clinicians now, when you are doing a patient record audit, be very hard on yourself, be very honest, because if you're not, and you end up in front of the GDC, they will be. And then act on your findings. There's the recurring theme of making sure you do something about it. Then re-audit in 3 months if you find that your records are disappointing, shall we say, and do it. I would suggest every 6 months if less disappointing. Some people advocate doing it annually. Personally, I think that's a bit too long, but it's a personal decision, and there are no rules or regulations around how often you should do it. Bear in mind that the whole objective is to protect you and make sure your records are going to help you, both with great patient care and also to help you if you run into problems. Recruitment's a big issue. I touched on that at the start. So a common finding is inadequate recruitment procedures and poor evidence that the practices are safe, and then incomplete pre-employment and recruitment checks. So personnel, which means therefore that personnel files are incomplete. Worryingly, we often do see no evidence of seroconversion for Hep B, and in some cases, professional indemnity is not in place, or the correct professional indemnity is not in place. So that could be, say you provide implants, but actually your professional indemnity only doesn't cover you to do implants. So make sure, if you're a clinician or a practice manager, that the correct indemnity is in place. So what should you have from personnel perspective? So what are the must-haves? You must have appropriate DBS disclosures, so that is relevant to the role that you fulfill in the practice. Clinical team members should have an enhanced DBS. Non-clinical team members can just have a regular DBS. You should have a CV with a full job history that lists all the exact dates from when to when that you have had, that you've been employed in other areas. Should have evidence of the right skills, experience, qualifications, training, evidence that team members are legally entitled to work in the UK. Satisfactory references, that can be a huge problem if you've got a very stable team that's been in place for a long time. If you want to get references for long-standing team members, which is probably a good idea, then just character references will do. So a couple of character references will suffice. How often, somebody's just asked this question, which we get asked so many times, how often should you redo a DBS? Sadly, nobody will tell us. So it is up to you to make the decision. If I'm going to make the decision for you, I would say every 3 years. I would actually also say that use an umbrella organization, because they keep it up to date all the time. So if you look for umbrella organizations that do ongoing DBSs, you can Google that. There are lots out there. They're very good, and it just means you don't really have to think about it. If you don't choose to use an umbrella organization for DBS, then I wouldn't leave it longer than 3 years. No, you won't find that anywhere in any kind of regulations. It is what the CQC expects, though, so it is a good thing to do. Thank you for asking that. Very common question indeed. You need proof of identity, including a recent photograph. You need to know about any relevant physical or mental health conditions. When I say relevant, I mean relevant to the person's ability to do the job. And of course, it is essential that personnel files are stored safely and securely. And the reason for that is that they contain personal data. So personal data, this is GDPR now, personal data is data by which you can identify an individual. So I'm not suggesting you use a chained filing cabinet. I am, though, suggesting that that it is very secure. So I've been to lots of practices where they say, "Oh yes, we keep our personnel files in metal filing cabinets," and I say, "Oh, and are they lockable?" "Yes," they say. And I say, "And are they locked?" "No," they say, "because we lost the key." So make sure that personal data is stored securely, because it should only be accessible on a need-to-see basis. Complaints handling now. So quite often see poor evidence of good complaints handling. I have spent a number of my roles, various roles over the years, helping dentists who've got into quite a bit of a pickle over complaints handling. And so I do know that it can really be a massive issue. So CQC are looking for good evidence of complaints handling, and it is sometimes missing. Or you haven't kept a record of your complaints, or looked at and analysed analysed it for trends. Or your complaints procedure is not readily available for patients, or it is not obvious that you even have a complaints process. So it does need to be made clear to patients that you do have a complaints procedure. Must-have checklist again here. So make sure you have a complaints policy with a named person responsible for managing the complaints. This should be up to date, in date, signed and understood by all. Make sure you've displayed all the right stuff in the practice too. I strongly recommend that you have a complaints tracker. It's not a requirement as such, but it is very, very helpful, particularly for just seeing whether you've got a trend. Is there a trend here that says patients never seem to know how much the costs are going to be? Is there a trend that says patients feel that they are not, that their treatment plans are not being explained adequately to them? Is there a trend that says that reception staff always feel a bit rushed? So what you're looking for is things that keep happening, and complaints can often be a very good way of keeping track of that. And then have your complaints tracker, analyze it for trends, and then take action and have evidence that whatever's come out of that analysis, whatever actions you've decided to take, have been implemented. Otherwise, yet again, it's a pointless tick box exercise. Also on the must-have checklist, evidence of action taken to avoid a recurrence. Hopefully, evidence of satisfactory outcomes. Now, that isn't always going to be possible, bearing in mind that what the definition of a complaint is, which is an expression of dissatisfaction about a service or treatment, whether it's justified or not. Tough, I know, but that's what it is. So you may not always be able to reach satisfactory outcomes. And if you can't reach a satisfactory outcome, then you must make the appropriate referral. If it's an NHS patient, you refer to the Parliamentary Ombudsman. And if it is a private patient, then you refer to the Dental Complaint Service. But you can't just leave it as, well, it hasn't been satisfactory. So you just do need to offer a referral. Patient might not take it, but you do need to offer it. Other frequent areas. Next one is adequate supervision and induction training for new recruits. Up to date, making sure everybody has up to date CPD records. So that's quite a headache for practice managers and practice owners to keep on top of. You do need to be sure, though, that everybody is up to date with their CPD. Obviously, for GDC registrants, particularly important, because if they are lacking in their CPD records, then and it's the end of a cycle, then the GDC does remove people from the register. And you never want that to happen. And they are brutal about being rigorous with that. So just keeping on top of the CPD records is important. And then poor evidence of ongoing training. So, training should always be ongoing. But, things like start team meetings and, events where you go through your policies and that sort of thing, that all counts as ongoing training. And then, of course, there's the big, long list, which I'll come to in a minute, of training that should be in place. So what can you do about that? So ensure all team members are appropriately supervised, whatever that happens to mean. So perhaps you have a trainee dental nurse starting with you, make sure they have the appropriate supervision. You have perhaps a dentist who didn't qualify in the UK come to work with you, having passed the relevant hurdles. Make sure they are appropriately supervised. And I can't be any more detailed about what appropriately is. That is a decision that you must make based on the individual that is being supervised. Make sure they're supported when required, and make sure that they have regular appraisals. And those things will all count towards good governance and demonstrating that you are well led, as does this. So have regular team meetings. I would encourage you to have written agendas. I would encourage you to keep minutes that you then circulate to the whole team. And that old chestnut again, have evidence that actions arising from the team meeting have been completed. And do try very hard, and we've had this problem in our practice in years gone by, that your team meetings don't just turn into a moaning session. So, perhaps think about some ground rules, like if you bring a problem to the team meeting, then also bring your ideas for a solution. And that makes it a whole lot more positive experience. Provide in-practice training. We've talked about how you can do that. There's a huge amount of online training available now. GDC does specify, though, that evidence of training should be blended, so it shouldn't all be online. Some of it should be face-to-face, which I really, really agree with. So something like safeguarding training, for example. Again, personal opinion here, but I think safeguarding training should happen ideally in the practice and ideally face-to-face. But have top-ups online, perhaps have face-to-face 1 year, and then the next couple of years, or whatever you decide is appropriate, then top it up with online training. But something like safeguarding training is really, really difficult to get enough information out of just for online training. Make sure all team members have a personal development plan, and as mentioned just now, make sure the enhanced CPD requirements that the GDC has are on track, so you don't get caught out. So I've got 3 slides now with what is essential training from the CQC perspective. Some of these things are also GDC recommended subjects, and you don't need to write all of these down because you'll get the PDF and the presentation anyway, and I'm not going to read them all out to you either. Or apart from, just pick out a couple of things. So management of healthcare waste. So the regulations around that changed quite a lot in 2023. So just make sure you're up to date with what the regulations say on that, and your training is up to date. As I said, I'm not going to read all of these out to you. They will be in the presentation. I'm just going to pick out a couple. So autism and learning disabilities is a relatively new one that is important to make sure that that you covered. awareness of. It's not detailed, it's just an awareness of. And then if you undertake sedation in the practice, make sure all those involved have intermediate life support training. So infection prevention and control procedures not always followed. And so what can you do about that? Well, you need to comply with HTMO 105. You need to make sure you have the appropriate infection control training. That can be done online, and obviously there are a lot of face-to-face courses as well. Make sure you do a 6-monthly infection control audit and have evidence you've acted on the findings. Don't just tick the boxes. Your infection control policy should have a named lead, and the descriptions in your policy and procedures should describe your infection control procedures. They should not be generic. So the thing that really sends the CQC down a rabbit hole is an infection control policy that says, this is the infection control policy for brackets, insert practice name, because that tells them that it's a generic policy and is not applicable to your practice. Make sure you have adequate ventilation and think about that. And another next area, I'll answer all the questions at the end if I may now. Thank you for continuing to ask them, really helpful. Other frequent areas we find, this is really, really frequent, emergency drugs and or equipment out of date. Obviously the biggest offender there is adrenaline, so make sure that you have a means of checking for that. Don't let your CPR, basic life support training, go unupdated, so make sure it's current, and we've already mentioned ILS training if you do sedation. So where do you get all the guidance from on what you should do with medical emergencies, equipment, drugs, training, and so on? That is contained in the UK Resuscitation Council's guidance, and here are some links for you to take you to 2 documents. One is primary care dental care equipment list, and the other is quality standards. So make sure that you comply with everything in those, because that is chapter and verse on what we should do with emergencies. So the CQC is looking for evidence, as I said earlier, that your practice provides care that's safe, effective, caring, responsive, and if it's well led. Now, you will notice that I have highlighted 3 of those in red. So that is, are you effective? Are you caring? Are you responsive? And the reason for that is that actually the only person that can tell you whether you are effective, caring, and responsive is actually the patient. So this is where feedback comes in and is really important. So make sure that you do that you get feedback from your patients for those purposes, and actually not just for regulatory purposes. Do it because it's important that you know what your patients think. And I know that obviously all NHS practices have to complete the friends and family test. Personal opinion again here, it's not enough to tell you whether your patients are happy with the service you provide. So my view again would be that go a little bit more than you actually need to do, and ask your patients other questions. The questions you use are important, as is benchmarking. Benchmarking means that you compare your practice with other practices. Ideally, if you can, do it digitally on a tablet or a URL to complete at home. This is how we do it at Dentistry Compliance. So we have a list of questions, and then the patient has to say whether they feel confident, quite confident, or not confident. And so I think it's very small writing on there. I think it says I'm involved in all my treatment decisions, or something like that anyway. So the patient then has to say whether they're confident, quite confident, or not confident. Now, I would say here, never mind what the regulators say, wouldn't you want to know whether your patients feel confident, quite confident, or not confident in whether they've had all their treatment options explained to them. There are lots of other ways of doing it as well. This is just how we do it. So that's patient feedback. You also want to get feedback from your team members. That should be anonymized. And then back to that old chestnut of having evidence of actions taken as a result of feedback. And then just a couple of other things, just a little reminders here. So when a CQC inspection is happening, they always focus on safeguarding, which is one of the reasons I mentioned the importance of training and making sure that you know, every team member knows what to do if you either suspect or have evidence that there is a safeguarding issue. So that safeguarding is, and so it should be, extremely important. They also focus on an understanding of the Mental Capacity Act. So again, make sure that all your team understand what the Mental Capacity Act is and understand how it is applied in dental, in any clinical situation, but obviously you're going to look at it from a dental perspective. So you're basically, the Mental Capacity Act is about assessing somebody's capacity to give consent to treatment. Also mentioned this, but it's worth just going over it one more time. They will look at patient records, they will look at staff personnel files, they will look at team meeting minutes, they'll check emergency kits and drugs, and they will expect audits and actions arising to have been implemented. Now, the biggest problem with all of this is that you don't know what you don't know. And things change often, and sometimes things go under the radar, and you know, I wouldn't blame you if you didn't know that HTM 0701 had changed in 2023, because there is so much stuff to do. So there is this really big issue that you don't know what you don't know. And then there is this fear, I think, in a lot of practices. Well, how do I know if I've got it right? How do I know if I've interpreted this correctly? Particularly if something comes along that you think, oh dear, this isn't how we used to do things at all. I'm talking here about HTM 0701, which is all about segregating waste in a different way, and not how we've done it in the past. So how do you know if your interpretation is correct? And then this may not be the same question, actually. How do you know if your interpretation is the same as the CQC? So have the CQC fully understood what the changes are? So these things create quite a lot of anxiety, and there is a huge amount to balance. There is, however, help out there, and the right technology and digital solutions can definitely help you. So what do I mean by that? Well, I imagine that a huge number of you will probably have compliance management software. And if you do, I'm really, really pleased that you do. There are a number of companies in addition to, or a couple of companies in addition to us, that provide compliance management software. And compliance management software should be about automating compliance processes and procedures, things like automating audits, digital checklists. We at Dentistry Compliance also provide techie solutions to the consent process. So there is a lot that technology can do to help. Now, this specifically is not a sales pitch. All I can tell you is how we do things, just really for you to think about. So we have compliance management software, so do other providers that schedule and manage all the compliance tasks. Our emphasis is on making it as simple and intuitive as possible. And we really try very hard with that, because we know that running a dental practice is, this is only one part of running a dental practice. We have automated audits in all of those things, so that it makes it very easy for you to do it and easy for you to understand the results, and an action plan. We have a comprehensive compliance audit, tells you where you're compliant, tells you where you're not, and then again, an audit report and a dated action plan. We have an automated infection control audit, which mirrors the IPC audit. Our audit, though, we do keep up to date. So during COVID, we updated it to really to comply with all the transmission-based procedures that were introduced. We have automated checklists and logs. Now, even if you don't have a compliance system and you don't have access to automated checklists and logs, those are the sorts of logs and checklists that you should be having. So again, this will be in the presentation that you are free to use. It'll be in the PDF, obviously, as well. So it's quite a handy checklist for you. Consent is a big passion of mine, actually, because I have spent so many hours helping dentists who thought they had consent and then found out when in front of the GDC that they didn't, or it wasn't valid. So this is a really simple tool that patient watches a 3 to 4 minute video and then answers questions on whether they've understood it or not. And whilst nothing is perfect, it's better than what currently happens, because I think a lot of clinicians think they've got consent that's valid, but actually it's probably only informed, which is where the patient has been informed of stuff, but the understanding hasn't been there. Just a warning, though, about techie stuff and digitalization. Do make sure that it doesn't create more work for you than you need. We strongly believe that compliance systems should support the day job and not turn into the day job. However, as I've said on a number of occasions, there is such a lot to balance. And if any of you are feeling like this poor gentleman tearing his hair out yet again, and feeling as if you're staring down this long tunnel of confusing regulatory requirements, you're not alone in feeling that, and you're also not alone because there is support out there. Now, I think what the Dental Care Provider Board is doing for Greater Manchester practice is fantastic. I really do. So the idea of what they're trying to do for you is to give you tools and information and learning that will allow you to demonstrate continuous improvement. Hats off to the Dental Provider Board in Greater Manchester, and thank you again to the team there for inviting me to do this. And we can help you. Others can help you too. We've also agreed with the Dental Provider Board that if you require more help because you are in a bit of a pickle, or you just you don't have enough staff to do what you need to do, then we can help you with that as well. And we have come to an arrangement. Sadly, the Dental Provider Board is not going to pay for it. You'd have to pay for it yourselves, but we have agreed special rates for all of you if that is of interest. And if it is of interest and you would like more information, then please scan the QR code and do book a 30-minute, no obligation demo, just so that you can see what you could have if you wanted to. And then also, if you want to have a look at the consent product as well. Now that is me finished now. And so now what I'm going to do is look at all the questions that have come through, and huge thank you to all of you for that, for asking those questions. So I've done how often do you need to redo? Where would this so about DBS? So the next question, good question, they're all good questions. Where would this information about DBS checks be? On the DBS website. So go on to the DBS Disclosure and Barring Service website and you will find information on there. Also, Google DBS check umbrella organizations and all of that information will be there for you. Let me know if any question I answer isn't answered fully enough. If a team member has not officially disclosed a mental health condition, but has been absent for mental health or verbally mentioned it, how do we log this in a personnel file? I think that you just log it as it is. I think that if they haven't told you about a mental health condition, then you can't have logged it. And actually, it might be a new mental health condition. If they've only mentioned it verbally, then I would have that in the personnel file. So just have it under somebody's personal details and have it kept safe, confidential, which is why I went on so much about keeping personal data very safe, but do make sure that you have logged it. Which CPD is essential for apprentices, please? What a great question that I do not know the answer to. So I think, I presume you mean apprentice, do you mean apprentice questioner? Do you mean, I won't name you, do you mean essential for trainee dental nurses? Or if you could perhaps just expand on that a little bit, that would be helpful. And then we've got a question here about ventilation. So I mentioned adequate ventilation. I'm really pleased somebody's picked up on this. This was contentious during the COVID pandemic. Are the regulations dictating the number of air changes per hour published? Yes, there are. They are the buildings regulations for healthcare buildings, and they have been around. We moved our practice in 2000 when did we move it? Maybe 2000, and we had to comply with building regulations then. And it is, the answer to that is 10 air changes per hour. Now, I think that as the questioner so rightly says, it was contentious during the COVID pandemic, and there are some practices that simply can't make that happen. And so, you know, there are things like air cleaners that you can use. And I think the CQC are not going to be checking that you've got adequate ventilation. This is a thing for you really to be making sure that you are as safe as possible in your practice. So do whatever you can to increase the number of air changes per hour. You will find it in the building regulations though. What review, next question, what review period should be on the policies? Annual, yes, absolutely. Annual, it should also say annual unless there are significant changes in the meantime. Now, if nothing changes, then all you need to do is just say you've reviewed it and then put a new renewal date in. They will want to see though that you have kept on top of it. Which is why it's important you don't have so many policies, you can't stay on top of them all. Question relating to apprentices, nurses. Do you know, questioner, I don't know the answer to that. I think probably some good people to ask would be the Dental Nursing Association, or ask Lisa Bainham from the Association of Dental Administrators and Managers. I will try and find that information out for you, and then ask the team at the provider board to send that question out. So it's reasonably rare I get a question I can't answer, but I can't answer that. And then going to set up for your 2 p.m. patient. Quite right, absolutely. Thank you all very much indeed for attending. Please do keep the questions coming, and I'm going to stay here till 2 o'clock to the bitter end. So if anybody wants to stay here with me, then I'm very, very happy to be here and answer any more questions. So, it says more messages have come in. Good. Oh, that's very nice, and thank yous. My huge pleasure. As I said, for some bizarre, weird reason, this is my passion. So this is a dream for me doing this, and I'm pretty sure you're going to think I'm extremely weird. Right, so there's a gentleman here with his hand up. Please do ask your question.
No, it's just in my position as chair of Dental Provider Board, Pat. I just wanted to thank you on behalf of the Dental Provider Board for an excellent presentation. I hope it was informative for everybody. And I'm not sure if you'd mentioned the fact that there are more presentations in the pipeline? Potentially.
I did at the beginning, I did,
Okay.
and yes, there are. And the dates, the guys at the provider board will be sending out the dates. I shall get those organised pronto this week, and they will be sent out. You're also, delegates are also going to be asked on your feedback forms if this time works for you, or if you prefer a different time. I think it's quite good as a lunch and learn type thing, and also there will be recordings of the webinars as well. Yes, so I did mention it right at the beginning, but that's now quite a long time ago.
Thanks.
You're welcome. Right, another question here. Somebody else with their hand up, please. Yes.
Yeah, it was just to mention, you did come across complaints handling in the excellent presentation. One of the other people we have speaking in this series is going to be the webinar with the head of complaints at Greater Manchester, but we've also got the spokeswoman from the Parliamentary and Health Service Ombudsman coming to give insight and feedback on the most common complaints and how they deal with them and how they could be avoided. So I would ask everybody who's been here today, you're welcome to come to that. And Pat, if you would be interested, I'll certainly send you a personal invitation, because you might not be a practicing GDP in Greater Manchester, but you're very welcome to come and listen to that if you feel it would inform you at all.
I'd love to, thank you. It's one of my pet subjects, actually, is avoiding complaints. One of my previous lives was as clinical director, firstly at Oasis, the dental corporate, and then secondly at Dentex. And so I spent a huge amount of time helping clinicians with complaints. And so I have my own list of frequent things that frequently cause complaints and how to avoid them. I will be really, really interested to hear another presenter speak about this. So I'd be very grateful for that. Thank you.
Welcome.
Any other questions? Right, I think we've got some more. Lots of very nice thank yous. You're very, very welcome. Very welcome indeed. Anybody else want to say anything? Ask me a question in person.
I think, Pat, there is a question there from one of the delegates. Do you know of any good training practice manager courses to go on by any chance?
Yes, I do, actually. And again, I think ADAM, the Association of Dental Administrators and Managers, is a very good place to go for guidance, actually, from them. So I think it's called Aspire Training. They do very good practice manager training courses. And again, let me look at that in a bit more detail. So I need to find out about CPD for apprentices, and I will also get you the ADAM's contact details. So that can be sent out.
Brilliant, Pat. Can I just add to that for any of the delegates who are practice managers? We actually have got a practice managers forum set up as part of the Dental Provider Board. So if you're interested in getting involved in that, if you want to maybe contact, I think Rose is on the call today, if we can maybe do that through Rose, and I'm sure she'll be able to put you in contact with the people that organise the practice managers forums, because it's distinct, it's the practice managers themselves. It gives them an opportunity to exchange ideas without the principal perhaps looking over their shoulders, and it gives them an opportunity to maybe discuss things that they maybe wouldn't want to discuss in front of other people.
Great, thank you. And then we've got a couple more things come through. So sorry, just to double check about DBS, did I say that 3 weeks is 3 years is the expected time? I did. I did say that this is a personal view, but from experience, that is what the CQC inspectors are looking for. But nowhere is it written that you need to update DBS every 3 years. It is meant to be down to the provider themselves to make that decision. But given that it's a decision a lot of practices find just too difficult to make, that is our opinion of what is the right thing to do. And then somebody there has put, I've had 2 inspections in the last 2 weeks. 2 inspections in the last 2 weeks, and these are the most useful tools to use for presentations. That's great. So, and it's the link to the Mythbusters. That's what the series of webinars is going to be about. Right. Then there's a question here that says, does it apply for every single person, including the provider? I think you may be meaning DBS. Yes, it does apply to everybody. And then somebody else has posted here is that you don't have to renew them for existing staff unless you feel there is a risk like conviction or suspicion. Yes, that is sort of true, or true maybe. That is not what the CQC expects, though. So, and since you probably don't want a stand-up argument with them, I think just for the sake of completeness, because they do focus heavily on DBS, I think you are safer to renew them at whatever intervals you feel are appropriate. Or if you don't choose to do that, then to do a risk assessment. But my view would be to use an umbrella organisation, and then you don't have to worry about it because it just happens in the background. Any other questions, comments? Help needed anywhere? No, okie doke. All right. Well, it's 3 minutes to 2 now, and I'm sure you have much more important things to do than sit and listen to me. So I'll bid you all farewell for this one. Look forward to seeing you on the next one. I haven't decided exactly which Mythbusters I'm going to go for yet. On your feedback forms, though, when they come, please let me know what your favorite subjects would be for me to explore next time. Bear in mind, there's another 6 of these webinars. There are 42 Mythbusters, so some of the webinars will combine Mythbusters so we can try and capture all of them. But if you let me know what your priority would be, then that would be helpful. Good, and I wish you all a good afternoon. Thank you again to Rose and the